Hello guys, this is Indian Medico, and in this video we are going to discuss about Central Serous Chorioretinopathy, which is abbreviated as CSR. CSR is an idiopathic disorder which is characterized by localized serous detachment of sensory retina at macula, which occurs secondary to leakage from choriocapillaries through one or more hyperpermeable RPE sites. CSR typically affects one eye of a young or middle-aged white man. The male to female ratio of CSR is 3:1, that is, it is more common in males. When it occurs in females, those females tend to be older. Now let us discuss about the forms of CSR. There are two forms of CSR. They are acute CSR and chronic CSR. Acute CSR is usually self-resolving within 3 to 6 months. Coming to the risk factors for CSR, a single nucleotide polymorphism involving complement factor H gene on chromosome 1 predisposes to chronic form of CSR in whites. Use of steroids in any form is a major risk factor for the development of CSR. This includes endogenous Cushing syndrome. Other risk factors include Helicobacter pylori infection, renal dialysis, systemic hypertension, psychological stress, pregnancy, and sleep apnea syndrome. Coming to the symptoms of CSR, there can be unilateral blurring of vision, metamorphopsia in which straight lines appear curved to the patient, micropsia in which objects appear smaller to the patient, and mild dyschromatopsia or defective color vision. Coming to the signs of CSR, the visual acuity will usually be 6:9 to 6:18. The visual acuity improves with a low strength convex lens. That is, it improves with a plus lens. This is because of the correction of acquired hypermetropia from retinal elevation in cases of CSR. There can be round or oval detachment of sensory retina at macula, as you can see in this picture. The subretinal fluid may be clear in early lesions or they can be turbid. Precipitates may be present on posterior retinal surface. There can be depigmented RPE foci in the form of small PEDs within the neurosensory detachment. Small patches of RPE atrophy and hyperplasia elsewhere in the posterior pole may indicate site of previous lesions. These old lesions can easily be seen on fundus autofluorescence imaging. This picture shows areas of RPE atrophy which indicates previous CSR lesion. In case of chronic CSR lesions, there can be substantial underlying atrophic change. The fluid can sometimes track downwards in a gravity-dependent fashion. This can lead to the formation of gravitational tract, which is easily seen on FAF imaging. Chronic lesions can occasionally progress to bullous CSR. In case of bullous CSR, there is a large single or multiple serous retinal and RPE detachment. In all cases of CSR, we have to rule out congenital optic disc pit. This is because congenital optic disc pit can also present with neurosensory detachment. Coming to the course of CSR, there can be spontaneous resolution within 3 to 6 months with return to near normal or normal vision in around 80% of patients. Recurrence is seen in up to 50% of cases of CSR. 15% of patients of CSR follow a chronic course lasting more than 12 months. Prolonged neurosensory detachment is associated with gradual photoreceptor and RPE degeneration and permanently reduced vision. This can also be seen in cases of multiple recurrent attacks of CSR. Cystoid macular edema, choroidal neovascularization, or RPE tears can develop in a small minority of CSR cases. Coming to the investigations done for a case of CSR, first one is Amsler-Gill. This confirms metamorphopsia corresponding to neurosensory detachment. We can do OCT. OCT shows optically empty neurosensory elevation, as you can see in this picture. One or more smaller RPE detachments precipitates on posterior surface of detached retina and thickened choroid can also be seen in OCT. OCT can also demonstrate degenerative changes which can be seen in chronic or recurrent cases of CSR. Now let us discuss about fundus fluorescein angiography in a case of CSR. There will be early hyperfluorescent spot that gradually enlarges. This is called as ink blot appearance. Less commonly, it can form a vertical column which is called as smokestack appearance. This is followed by diffusion throughout the detached area. These two pictures show ink blot appearance and these two pictures show smokestack appearance. The underlying PED may be demonstrated by fundus fluorescent angiography. There can be multiple focal leaks or diffuse areas of leakage, particularly in chronic or recurrent cases of CSR. Coming to fundus autofluorescence, there will be focal decrease in fundus autofluorescence at the leakage site and at sites of old lesions, as you can see in this picture. Gravitational tract can also be seen in chronic cases of CSR. Coming to ICGA findings, early phase will show dilated or compromised choroidal vessels at the posterior pole. There will be mid-stage areas of hyperfluorescence due to choroidal hyperpermeability. ICGA will also show subclinical foci of CSR. Coming to the management of CSR, observation can be done in many cases of CSR. This is because spontaneous resolution can occur in up to 80% of cases of CSR. It is important to remember that all treatment modalities can be associated with RPE tear formation, which can also occur spontaneously. Some treatment options for CSR include oral spironolactone, which is given in the dose of 400 mg twice daily. This will lead to faster resorption of subretinal fluid than no treatment in acute CSR. It is important to discontinue corticosteroid treatment, particularly in chronic, recurrent, or severe cases of CSR. Now let us discuss about laser treatment in CSR. Subthreshold, that is micropulse diode laser, can be used. This is given to the RPE site of leakage and it is associated with significantly less retinal damage on OCT than conventional photocoagulation. This picture shows a case of CSR before treatment with subthreshold diode laser and this is after treatment with subthreshold diode laser. As you can see, the neurosensory detachment has resolved. The other laser treatment option is photodynamic therapy. In this case, 30 to 50% of dose used for CNV is used in conjunction with 50% light intensity. This leads to complete resolution of CSR, including severe chronic cases. It is also associated with a considerably lower incidence of significant choroidal ischemia than higher intensity regimens. Other treatment options for CSR include intravitreal anti-VEGF agents, which is used in conjunction with photodynamic therapy, aspirin, beta blockers, mifepristone, and eplerenone. Thank you.